over a couple housekeeping items. If you haven't already, please mute your lines. We will have time for questions and answers at the end of this session. You can ask a question by typing into the chat box, which is at the bottom right-hand corner of your screen. Please turn off any applications or windows that you aren't using to save bandwidth. And just so you know, this webinar is being recorded and will be uploaded to our website at scoheducation.org. And so I'm excited to introduce our presenters today. We have Dr. Christine Schaefer, who is an internist and has dedicated her career to improving the health of Chicago's underserved. In 2011, she founded the Northwestern Medicine Follow-Up Clinic, which was later renamed Northwestern Medicine Transitional Care. As medical director, Dr. Schaefer provides clinical care, vision, and leadership for the practice, collaborating with partners within Northwestern Medicine and in the community. And we also have Megan McVane, who joined Northwestern 6 years ago and has worked in various roles, including direct patient care, patient engagement coaching, and she's currently the social work clinic leader at Northwestern Transitional Care. Megan supervises a team of health advocates who work to address social determinants of health and empower individuals who navigate their healthcare needs. And with that, I will kick it over to Dr. Schaefer. Can you advance the slide on here? Mm-hmm. There we go.
Hi, everybody, and thanks for joining us. So we wanted to talk a little bit about our transitional care model and how we use this approach to identify and address psychosocial issues and medical needs in a clinical practice. Sorry, there we go. Advance. So just to give you kind of an overview of what we're going to talk about, we wanted to go over kind of some of the missions and values of our practice, briefly go over sort of the care model and some of the lessons we've learned, specifically touching on how we talk about some difficult issues, and then close with a couple case examples, which will hopefully help us answer questions in some real-time, in a real-time way. There we go. So this practice has been around since December of 2011. It was started by the hospital as a way to address patient needs around care transitions, specifically those seen in the emergency department of the hospital who didn't have a place to go for care after they had been received that acute care experience. And from that, we've developed a care model to address patients who are bridging the transition from the acute care setting to home. Our mission is to increase access and improve health outcomes for at-risk patients with complex medical and psychosocial needs through an integrated, interdisciplinary team which provides high-quality, empowering, and compassionate transitional care to our patients, to other providers, and community partners to meet all of their needs.
So our values, we're an innovative clinic, innovative to meet the dynamic and ever-evolving patient needs, collaborative community to empower change, determined advocates for patients and policies, and responsive to data and quality indicators to adopt new practices.
Our goal as a practice is to go from a single location practice to a respected national leader in transitional care medicine. So we thank you for listening to this process and giving us some feedback on what you've learned.
Sorry, we're having trouble advancing the slides, so be patient with us.
Okay. So just to give you a brief picture of who we serve. This is a map of metropolitan Chicagoland. The red H in the center here is where our hospital is located, and this is kind of all of the neighborhoods of Chicago. As you can see, darker is more densely referred to the care practice. And those areas are also, for those of you familiar with Chicago, some of the lower socioeconomic strata zip codes. So Westtown and Humboldt Park, which are kind of in this area here, South Shore, which is down here, Edgewater and Uptown are up here, and then Austin is here. In addition, there's a little loop right around the practice where a lot of patients who live on the streets come for care to our facility as well. So this map does overlay the map of patients who receive care from the hospital and the emergency department, but the darkest areas actually are more specific to our practice than the institution as a whole. So we often talk about who to refer and how does that process happen. Go ahead, Megan.
Yeah, so our criteria for our clinic is anybody that's been in Northwestern's emergency room or Northwestern's hospital within the past 6 months that does not have a primary care physician. So Christine and I have done a lot of work with the hospital as a whole and the emergency room. I'm kind of coaching through what to ask and how to identify if a patient doesn't have a primary care provider. So some of the big questions we like to make sure that are asked is who sent you to the emergency room or the hospital? And if it was the urgent care, typically a patient can't refollow with urgent care. So that identifies they need a primary care doctor. So that follow-up question of can you see that provider back for your follow-up care? If a patient doesn't have a primary care doctor, the goal is for them to come to transitional care. If they do have a PCP, but for some reason that primary care doctor can no longer accept them, it's appropriate to send them to transitional care. An example of this is like changes in insurances or loss of insurance. If a patient wants a new primary care doctor, they can come to transitional care. We see a lot of patients that are part of FQHCs but haven't felt that they've received the best care. So we'll bring them into transitional care and kind of coach them through what it feels like to be in an FQHC and how to really succeed in those environments. When we recognize patients as frequent utilizers of the emergency room, that really kind of says that their care is not working right now, even if they do have a primary care doctor. So we want them to come into transitional care. If we think they need extra help, seem overwhelmed, need medication vouchers, or asking for bus cards, anything that gives you kind of a red flag that this patient isn't succeeding in healthcare and managing their healthcare, they can come to transitional care. So just internally, we have a referral system in Epic. We like to see our patients within 7 days or less. And the insurance is always a big barrier, so we can accept any form of insurance or not insured patients. The only limitation is like out of network with Northwestern insurances, but any out of network Medicaids we can see, Medicares, we have a lot of services around learning how to use those benefits, so we'll see anybody.
And that's an important carve out, I think, that our institution has given us the privilege of utilizing to really meet the needs of these patients where they're at. So I think this highlights one of the key pieces of this practice model, which is to identify people who have a variety of needs for care and then send them to one central receiving spot where those needs can be fleshed out, clarified, and then met, with the goal of providing a lot of service in an intense relationship and then moving people on to the next location. So kind of an overview of the care model. As Megan went over, we coach our providers how to refer people in. And we also coach our patients on what this space is. This is not a place of care that is common, and many people have never encountered it. So we think about it as creating a solution to a healthcare crisis. So for us, we view any emergency department visit or hospitalization as a crisis, and that leads to an opportunity. The opportunity is to address the gaps in care that led to that crisis and stabilize the patient so that those crises don't recur. So we tell our patients when they phone in that they're going to have a 2-hour initial visit. That's an evaluation that involves many team members in the transitional care space. So they come to one place and all the providers go to them. And together those providers and the patient come up with a care plan. Subsequent visits are usually 1 to 2 weeks later, with an average of 4 visits for an average patient, although many patients do stay longer if they need it. The goal is in that 4-visit series of appointments to address social determinants of health, acute medical visits, medication access, and other resources that need to be identified, get the patient functioning and managing their care, and then once they're able to function in a traditional 15-minute office visit, connect them to a partner practice, most often a federally qualified health center who's affiliated with the hospital for longitudinal care. Well, one of the key pieces is that we use real-time interdisciplinary and integrated care, and maybe Megan can explain a little bit about what that means.
Yeah, so we'll go into it in more depth when we look at what the first visit looks like, but we have a social worker, me, do a consistent assessment on every patient. So when I'm doing that assessment, it's the same information, the same evaluation system that gets used on every patient, so we have consistent data on each patient. We use that assessment to really tailor services and dictate case management supports that we'll put in place.
So our staff includes 1 full-time physician, that's myself, Christine. We have 2 advanced practice providers who are 1.8 FTEs, so one of them is a little less than full-time. We have 0.2 psychiatrists, so 2 half days of a psychiatrist time. In addition, Megan is our full-time social worker. We have 1.5 social workers who provide behavioral health therapy, and 3 health outreach workers or health advocates. In addition, for administrative and clinical support, we have an MA, a nurse, and then kind of a front desk ops coordinator, PSR. We also have kind of broadened our staff by using education to our colleagues as an opportunity to kind of increase the access for patients. So we educate the pharmacy residents who are doing their PGY1 or PGY2 year in the hospital by collaborating with that residency program. In addition, we've collaborated with the Feinberg School of Medicine internal medicine residency and trained those residents in their second year on a rotation about transitional care, as well as some continuity clinic experience for some of those residents. And we have some medical students who also share the practice. So by adding educational experiences, we've really increased the capacity of the clinic without adding to our core staff and adding to our costs.
So the first thing, when patients come into transitional care, the first thing that we do is a social work assessment. Every patient on their first visit meets the social worker first and really sets that stage for how we're going to look at social determinants of health. So I complete a brief psychosocial assessment. I look at things mental health, substance use, social supports, insurance, housing stability, health literacy, income, transportation, education, and food insecurity. So once I get this information, I go into our team room where we all sit as a team, providers, pharmacy, health advocates, and what I do is I give out a report on all of that information. I also concisely document it into the EMR under the social history, which is a great place to put this information because medical providers pull it into their note, and providers throughout the system also pull that social history into their note. So it's putting it in a place where it's highlighted so that all providers can see some of that information. So all providers caring for this patient know if they have a mental health disorder, know if they have substance abuse problems, know if they're homeless, know if they are not comfortable filling out medical forms. So I give a handoff with all of that information to our team, and right in that first visit, we are using those social determinants of health to incorporate them into our care plan. I also, once the provider is in working with the patient, assign patients a color, and we use 3 things to assign these colors. So it's kind of an aggregated risk score. We have green, yellow, orange, and red patients, and we look at 3 different things to do that. So the CHI is pretty common. That's an, what's your word that you always say, Christine?
It's a patient
validated.
Yes.
Validated tool that looks at patient activation. The LACE, which most people know it's the readmission score, and then the PCAM, which is a unique validated system that looks at social determinants of health. So
it's patient-centered activation measures, what the PCAM stands for.
Yeah.
And so I think, as Megan outlined, we look at these 10 social determinants because those are all included in kind of all comers common lists of things that we know interface between medical and health, as well as psychosocial components of well-being and health. And so by including all of these consistently, we're getting a good picture of the whole patient. And so I think first piece for us as a practice was identifying which are the key things we want to discuss, and then thinking about what we could do to address them, as well as overlaying that, integrating it into the medical care. I think the key piece is that it's a real-time integration, so we get that information and we take it into the room with our patients. So when I go in to see a patient, I know that this person struggles with homelessness, and that unless I work on something to address some of that piece, I can't worry about their diabetes control is not going to improve.
So this is the PCAM, just we wanted everybody to see it. The first section looks at health and well-being, then social environment, health literacy and communication, as well as service coordination. I would say a large majority of our patients, service coordination is a big thing, whether they don't have insurance or have a network that's really difficult to use or just don't know how to schedule appointments. So that one usually triggers pretty high for us. Social environment, if you have an individual that's homeless or facing homelessness, that's a big one that triggers for us. Health and well-being looks at both their medical health as well as their mental health and their ability to function with the certain impairments that mental health diseases can have.
So we've chosen this measure as a validated assessment because it included all the key areas that we thought were important, and we wanted something that would be comparable across institutions. We did this 7 years ago, and we're currently talking about maybe rolling into some of the more updated patient care measures, but at this point we're still using this one while we make the next step. So after Megan does this integrated social assessment, Yeah, sorry. I then, or the medical provider, myself or one of the advanced practice providers, takes that information and goes to meet the patient. While she's talking to the patient, I've reviewed the recent records of the recent discharge or ER visit, as well as distant records that we have electronic access. We've had our conversation, and then we go into the room to as usual, obtain a detailed history of the patient and do a physical exam. The other piece we add to this is a conversation we have with the patient about goals of care. So identifying key issues, usually before I've gone in the room, if a patient has some key issues that led to the ER visit, I bring those in as things that I think we can agree are goals, but I also ask them what their goals are. A quick example of how this is important is often that we're referred many patients who have high blood pressure in the emergency department, but often those patients aren't going in with high blood pressure. They're coming in because they hurt their knee at work or they slipped and fell. And so we want to make sure that while we address the key medical issues, which will improve life expectancy and lead to positive outcomes, we also want to address what's important to them. And that's one of the key ways we get kind of a significant collaboration and investment of the patients in their care. So the patient and provider will collaborate around goals. Usually we start with 2 or 3 key pieces and then 1 or 2 additional psychosocial determinants of health that are identified separately, sort of in collaboration, to put on the active problem list. We do a lot of education around the diseases patients have either been newly diagnosed with or managing less than optimally. We pair that with patient empowerment. Often I'm asked, what does that mean? And so my best way to explain this piece is that we like to give patients 5 pieces of information and management skills they can succeed at. So for example, if a patient has uncontrolled diabetes, we will often load their medicines into a pill box and teach them the simple plate method of carb management. So, you know, half of your plate is vegetables and a quarter is carbs and a quarter is proteins and fats. And so that simple process can be understood by anyone at really any educational level, doesn't require reading. And so the patient can start to implement that with whatever foods they have available so that the ratio of things is a better balance. In addition, by putting the pills in a pill box, they can successfully meet the goal of taking their medications daily. So in that simple way, we've kind of empowered them to succeed in that part of the care plan. If we set that as a goal, we're setting them up for success. I think that for patients who have been long excluded from care, it's critical to have immediate success or as soon as possible success experiences so they feel like their engagement has value. In addition, we acknowledge patient experiences and we set high expectations. Our expectation for our patients with diabetes is a hemoglobin A1C of 6 or less, just as it is nationally, even if they start out at an A1C of 16. And we want them to know that we expect them to have good health outcomes as good as any other patient in the health system. And we make a mutual commitment to each other. We as a care team say that we are here for you by having all of these providers interface with patients in that first long visit. We really demonstrate a commitment to them, and patients reciprocate by really making an effort around their care. We coordinate all the care plan appointments and kind of lay them out step by step, so again, we have an opportunity for success. So as another example, we don't schedule 6 follow-up appointments the next week. We'll schedule 1 with us and 1 other appointment that we try and pair on the same day of the week, so the patient comes to the hospital system 1 time, has a visit with whatever specialist they need to see most, and our team who can kind of coach them through, debrief that experience, clarify any care plan that might have been laid out by that specialist, and sort of support them through that process. So we tend to see them either right before that visit to coach them on what to say, or right after to kind of go over what the specialist recommended and implement those recommendations. We do have some critical medication supports. So as we mentioned on a prior slide, we work with the PharmDs in their residency, and they collaborate with us to really help support our patients around medication education as well as access. For us, we use pill boxes as a standard. I'm kind of a stickler on mandating that everyone tries it for at least a week. I will say in the 8 years we've been operating, there have been about 3 people who've hated it even after a week, and that's fine. We really ask them to give it a try because really most people find it useful and beneficial in reducing the stress on a daily level. We provide a very simplified grid medication list we find helpful for our patients to use with appropriate language modifications as needed. We have the capacity to provide some vouchered medications. So these would be medications dispensed from a pharmacy on site at the hospital, so the patient actually leaves the practice with all the needed medications in hand. We also use pharmaceutical assistance programs and apply for whatever we think we can get. as well as GoodRx for patients long-term. Our goal with medications long-term, and we look at this kind of as a long-term endpoint where we start them on acutely, so we want it to be as little changes as possible in terms of formulary. So we look to the long-term Medicaid formularies and GoodRx discounts if that's going to be what the patient uses, and start them on those medications up front, but provide that initial supply free while having a conversation with how much it's going to cost them and how much they need to save up to stay on these medications long-term. In terms of psychosocial needs, we, in addition to having those conversations with our social worker, we have the capacity to have some real-time integrated psychiatry, therapy, and trauma. This does not usually happen in the first visit. It usually happens in subsequent visits, because as you can gather from this conversation, a lot is going on in that visit. But if we do need to, for safety of a patient, we do have an on-site therapist who can provide a brief intervention for stabilization and support. We try to have our nurse close out that visit in the first visit, or if not able to, the health outreach worker will do that by doing a teach back of, okay, doctor said such, and what are you going to bring back to the next visit, and going over that so the patient can kind of restate what needs to happen when they get home. And the health advocates, sort of the final closer, they address the key piece of all pieces, which is insurance and access, which is a huge lift on their part, and without their work, we could not succeed, and our patients would not succeed. In addition to the heavy lift of insurance enrollments, we have a very generous financial assistance program through our hospital, for which we're very grateful. And our hospital is also generous in that it provides empiric eligibility for those patients who are screened and met to qualify or thought to qualify for state Medicaid, so that they can start getting full coverage without paying out of pocket from the moment that application is completed, while we're in the limbo of activating the state insurance. And Illinois is a particularly slow state, so the process of Medicaid application to active care is 6 to 8 months. So our hospital is very generous in providing that care up front, so that we don't put a stall on that and end up with more utilization. Go ahead, Megan, about the health advocates.
So the health advocate piece is, as Christine was saying, just invaluable. Like, I don't know where we would be without these health advocates. So they do a lot to help with insurance, links, a link which is food programs, food assistance in Illinois, government phones, transportation, and Christine has this philosophy, which I think is so perfect for our patients. In their first visit, our goal is to get them to come back. So we usually like to do one thing for us, in a sense, like setting up a pill box and teaching them to use the pill box, and one thing for our patients. So a lot of times our patients will come in with multiple things they want to work on, right? They want to apply for links, they want a government phone, and they want you to help with housing. So we'll really trigger one thing, and at the next visit, encourage them to come back, because we'll trigger we'll do the next thing at that next visit. So the government phones is a huge thing. It takes maybe 15 minutes for the health advocates to do, and it's really inspiring because the phone gets shipped to our office, and we give the patient the phone when they come back. So we kind of jokingly call it a carrot, right? You're going to come back for that thing, and you're going to see us again.
In addition, we obviously provide a lot of coaching around utilizing these services, so that, obviously people can use their phone for whatever they want. We encourage them to save some time so that we actually can call them back on our hospital phone. Sometimes we enter the hospital phone number, the main line in their phone, so they know when the hospital's calling, and they accept those calls. But those key pieces are key. And the other key piece is close follow-up. So I think that many patients who've not been in care, or who've had care in very brief settings as like a health screening at a church or at another public fund, have never had someone spend this much time with them, and that really is a huge carrot. But as Megan said, we try and tie a functional activity to coming back that we think everyone would be interested in. So for many of our patients who've never had health insurance, Medicaid is actually not the biggest motivator. For us as clinicians and care providers, it's the motivator, because we know that it'll help them stay healthy. But for our patients, honestly, the food card or the phone access are more critical pieces to them. And so we try and weigh that while we're working on the complicated insurance process with them and collecting a bunch of hard-to-find documents. We try and also work on the phone card and attach, in the state of Illinois, if you get a Medicaid or Medicaid insurance, you will have access to a food card, a link card. So we try and link those two things in patients' minds to motivate their participation. So this is kind of by team member. It's another way to look at this. The first team members, medical provider and health advocate, are seeing each patient at each visit. We talked about the social worker as the key introduction to the practice. She's not on this page because she is the key intro, and she's a reference and a resource for consultation, but doesn't see patients at subsequent visits as consistently. So it's on a PRN basis. But the medical provider and health advocate usually work as a team, and they see each patient every visit, and they tap into these lower 4 or 5 people as needed to meet patients' needs. The PharmDs we talked about, besides loading pill boxes and providing education, they're another person to help reinforce and teach back, as well as provide some, health education. After 2 visits in transitional care, we offer therapy services for patients who need it. We identify a lot of somatic complaints from prior complex trauma. In addition, many of our patients live in the inner city, and so there is innate trauma in living in Chicago, and that also warrants additional support or an opportunity for support. We used to offer this at the first visit and learned that that was just too much information and too much and it overwhelmed patients, so we sort of pulled back a little bit on that for most of our patients. Our nurse does direct medical case management as well as wound care, personal hygiene, and manages our DME. She's a great outreach worker for many of our homeless patients as well. We have 2 psychiatrists, which is something we really pushed hard for. Many of our patients come to us without diagnosis or inaccurate diagnosis of severe mental illness, and so clarifying that diagnosis and helping correct inappropriate labels is also a very important experience for our patients. And lastly on this list, but not because of importance, are financial counselors and Change Healthcare. We talked about that briefly before, but that's the key piece that our system uses to get patients long-term access to care, which is engagement in insurance or a financial assistance program. In terms of outcomes and lessons, we kind of group some social determinants of health in terms of what we assess and actionable items. I think it's important to put those 2 together in this way because a lot of times we hesitate to ask questions or assess needs when we have no actionable items. And so by pairing it this way, hopefully will help just provide our insight into what we think about. So for us, social determinants of health include any functional need that intersects with general health or the patient's ability to access or address their health. And so we look very broadly, as we discussed in Megan's initial assessment, but we think that that's key because it's sometimes the most broad areas that really affect one's ability to adhere to a care plan. And nothing angers me more than hearing that a patient is non-compliant when in reality we haven't asked the correct question to really ascertain what their need is. And so they are as compliant as possible, they just don't have the resources to address that need.
Yeah, so big things that we do in transitional care is put a community of support around a patient. So we demonstrate how important they are in taking care of themselves by putting a big team around them. So they're being seen by, provider, social worker, health advocate, nurse, and we're all working together to give them different pieces of information. We look and screen to see if they've told family or friends about their medical conditions, if they feel that there's people that they can call and do coaching around how to involve your family and friends in your healthcare. Christine's done a really good job with some of our patients of getting spouses to come to visits, going over pill boxes with spouses. So when we identify that there's health literacy concerns, putting support around who can help with that. A big piece that we also do is connect patients with community resources, and the slide that we have later on talks about some of those specific resources. But we're really key on identifying resources for job placement, housing, different mental health services in the community, just teaching patients to trust us, and then from there, trust our support networks and trust the resources that we give. So a lot of times we'll work with our patients to call those resources together, so we're making that warm handoff and that connection. Or if we make an appointment, calling that resource and letting them know this is our patient, they're coming, making sure they have the right records. And then a big part of what we do is connect with federal and state resources. So I think a really good example of this is we use Change Healthcare to get Medicaid applications started within our hospital. So it's nice because patients don't have to go to the DHS office to start that Medicaid application, and we allow them to see the success that that application gets, and then teach them to go to DHS to apply for their food benefits, because if they go to the actual office, it will get turned on that day. So really taking it one step at a time. We'll do this for you, but we're going to teach you to get to that next resource.
And a lot of times we make the teaching as at the level of the patient. So for the patient who just needs an address to get there, we give them the address. Patient who needs the bus route printed out for them and coach through which bus they're going to get on, where they're going to transfer, we do that. And so the goal is to really empower patients at all levels of functionality that they have the right to engage in the system. another example that seems kind of simple and maybe not so useful, but actually is very valuable, is that when we schedule appointments for patients, because we do all the scheduling up front initially so we can kind of get everything rolling, we ask our health outreach workers who do those appointments to schedule in the room with the patient. This gives an opportunity to see one, do one, teach one in terms of phone calls, and it's really critical for our patients to understand that it takes us 30 minutes to schedule an appointment, so they don't get offended or feel like someone wasn't giving them the respect they deserve when they call back. And also our health advocates, model, positive, cordial conversation and make small chit chat and some of those other niceties that really help patients feel at ease and let them know they can do the same. And so it's a great opportunity to show patients that, you're important enough for us to schedule this, but this is how, boy, it took us 30 minutes for us to schedule an appointment, and we call them every day. And so it also allows that opportunity to teach patients what kind of investment is needed to get the health care that they require. So I think we try and do a lot of modeling also of that. Just speaking to family, friends, and support groups, I just want to mention this again because I think a lot of our patients are hesitant to tell others about their health needs. Many people who've been excluded from health care view an illness as a personal failure rather than the natural result of their genetics or whatever else may have led to this illness. And so there's a lot of shame around even common medical issues like, oh, I have diabetes because I drank too much soda pop. And they sort of put themselves down often. And so by trying to reframe that conversation such that the patient is not the victim nor to be blamed, but really the person that we're trying to set up supports around, and encouraging conversations with family and friends in a positive way about the ability that they've done a great job of engaging and managing their diabetes, and look at how well they've done and how much better their sugars are by making these changes in diet. We can get friends and family to support them, which is key. And it just kind of opens up a different type of conversation. I like to call patients family or friends, whoever they feel comfortable, like one person per patient, so that we know at least one person outside the community of the clinic knows what's going on. And really, I have the conversation just that way. We really need someone else who's in your home court knowing what's going on. And then facilitating that conversation so the patient can start telling what's going on, and we can add in and really empower and praise the patient for all of their efforts in front of family and friends so that relationship in this space is very positive. And long term, they need their support because we're not a forever friend, per se. This brings us to another point that I think is really key when you're talking about integration of social determinants of health, and that's kind of how to talk about it. We train all, as we mentioned, the pharmacist residents and the internal medicine residents, and a lot of times when trainees come in for the start of their rotation, they're uncomfortable asking patients about safety in their own homes or sexual violence or feelings of being in danger in one's home environment because they're not familiar with that themselves. Thankfully, they've been in safe places. But I always encourage them to ask the questions, and my coaching is really threefold. If you're genuine and engaged and you're listening for any answer that's offered and able to validate, you can ask any question that you respectfully desire. So I ask the providers to be calm, to make good eye contact, and to validate and affirm whatever answer is received. In that way, we find patients are very trusting of their stories. And one of the key pieces of working in a trauma-informed manner is to be open to any answer. And so we talk about that with our trainees. Thank you for trusting me with your story. I'm so sorry this difficult thing happened. That is incredibly validating, and that's actually the first step of addressing the trauma itself and the feelings of the victim. And it doesn't require any expert training other than a willingness to be genuine and ask those questions and validate. We also feel that there's a strong value in that human connection and hearing of a story. When you as a provider in a white coat or as a nurse or social worker are asking a question and really committed to hearing that answer, you're giving value to that person's life experience. And that is really important. That's as important as the formal validation and affirmation that we ask people to provide. And so I think those are key pieces. And the last piece that I want to touch on, and Megan can take off a little bit, would be if we don't talk about the key critical issues to that person, we're never really going to address the elephant in the room, and we can't truly stabilize this patient in a way that works. Many patients come into the ER with physical complaints that stem from prior complex trauma, and if we don't really talk about that history, we can't truly address effectively the physical complaints they also have.
Yeah, so in addition to talking about difficult issues, we always talk about our practice as an incubator. and it's where you learn to participate in healthcare. So one interesting thing, too, that I think we do a really good job of focusing on is being appropriate in medical visits. We use transitional care as a space to teach patients how to talk to their healthcare providers. So a lot of times when our MA walks in, they'll be like, oh, baby, I'm fine today. And coaching through, I'm not your baby, I'm your medical assistant. I need to take your blood sugar today. So just being firm and teaching them how to succeed in a visit. They can try different things out with us, and it's our job to address what is appropriate so that they can succeed when they go into the community and other practices that won't be as tolerant as we are.
So the sort of last piece is when patients have been kind of tuned up and addressed and their medical and psychosocial issues are addressed and stabilized, and we're going to go over a case next, we want to connect them to care going forward. So we always say we're only as good as our receiving partners, and as our practice has grown, we continually meet with our partner practices, see what we can do differently, what we can do better to make those transitions and handoffs effective. We know at many locations the providers with whom we send our patients. If it's a really complicated scenario, we'll give them a call or we'll send the EMR records. We always send the EMR records, but we'll also make that provider-to-provider call. And so we most often use a launch checklist to make sure that we're all consistent with what happens to patients before they leave. This is an electronic grid in our EMR, and so you can check off things at different points. But the same things we assess on the way in, we want to assess on the way out. So we want to assess that the patient knows their medications, that they know how to pay for them and access them, that they then know how to get them and ask their provider for refills. And so we assess that as the medical clinicians each visit. We also clearly discuss what is the role of a primary care provider and how does that primary care relationship link back to their specialists at our hospital. The way our partner practices are set up, if we connect a patient to a partner affiliate of the hospital at a federally qualified health center that's affiliated, the patient can continue to get their specialty care at our main hospital medical center. And so that allows ongoing similar continuity with their same cardiologist, for example, or their same endocrine provider. And then, Megan, do you want to talk a little bit about what else happens from the pharmacy nursing and health advocate piece?
So the great part about this checklist is it's interdisciplinary. So the first section is done by the provider. Then we look at pharmacy and nursing. So they focus on medicines. Is the medicine in the regimen? Is the medication regimen in the patient's budget? Can they continue to afford this? Do they know how to reapply for prescription assistance programs? Do they know what logs to bring and how to bring all of their bottles to their follow-up appointments? And then for the health advocate piece, we look at, do they know how to get to that primary care doctor's office? Are they prepared to go there and wait? I'm trying to think of specific examples. Can they teach back how they'll get to and from? Is transportation figured out? And then in Illinois, as I'm assuming other states as well, Medicaid is a hard insurance. So we spend a lot of time teaching patients how to utilize their Medicaid benefits, making sure that they're enrolled in the right HMO plan for the places that they want to go, teaching them how to re-enroll every year in that plan, making sure they know when their redetermination date is, teaching them and walking them through the process of making sure the right primary care doctor is assigned so they can continue to get their care.
So a lot of coaching and teaching at the beginning, in the middle, and at the end to kind of reinforce what the key pieces are. So we wanted to go through a case. This was all kind of broad and largely contextual, but by giving you a specific case, I think it'll help outline some of the things and how they happen. So Mr. JC was a gentleman who was sent to us after a hospitalization for diverticulosis with an intra-abdominal abscess. He also had a COPD exacerbation, some high blood pressure, and some alcohol withdrawal. He was uninsured and sent to our practice. When Megan did her screen, he self-reported anxiety, so she screened him with we use a PHQ-2 screener, and then in his case, because he was mostly anxious, she added the GAD-7. And he also identified as homeless for 6 years. He had been sleeping on a friend's couch, and he sent his mail to his aunt's house. So when we hear that someone's homeless, we like to clarify, are they homeless sleeping on the street? Do they have a consistent housing partner at a shelter, or are they couch surfing? And if those are, any of those first three are the case, where does their mail go? Because that also helps us know, is there any stabilizers or anyone in their sort of small world community that we can potentially reach out to? He also, one of my other tricks is to ask patients what they've eaten in the last 24 hours. It gives me a big sense of kind of their functionality and their access. So if they have it eating only once a day and it's, you know, whatever they got handed on the street corner, that's very different than someone who's cooking a meal a day in a home or getting a takeout meal and bringing it back to their SRO. It gives me a lot of insight and kind of gives me a sense of overall where we're starting from. And then in terms of his other issues, he had been drinking daily, but not using other substances. And so from this initial assessment that Megan obtained, we came in with the medical idea of addressing his acute diverticulitis, which was fairly straightforward. We needed to voucher his antibiotics. We needed to address his smoker's asthma or COPD with some inhalers. We routinely use one of the pharmaceutical assistance programs from actually GlaxoSmithKline because they always have Advair and Ventolin, and you can get a year's supply at home. And so we started him on those medications as well as some tobacco cessation. And I think those actual medical pieces are probably the least of it. The more complicated pieces is how are the social determinants that have been identified overlay into those functional medical pieces. So Megan, would you want to talk a little bit about his housing and how we worked on that, as well as his access to food?
Sure. We got him applied for link benefits, which was great for the food. He also had cut back on his alcohol use, so he was having more money to buy food, and we connected him with places for free food near his work. With housing, too, we connected him with the local YMCA. I believe, is he back on the street now? Or
he didn't like the YMCA because he didn't feel comfortable in that facility, so he paid for a month's rent and stayed there for 2 weeks, and then he left. But I think, again, this is an example of how, you know, we were able to identify his aunt was the place to receive his mail, but he wasn't comfortable sleeping in her home because she had rules around drinking and smoking, and he wasn't able to abide by. We found the Y as an option that he could afford. He was actually working and making about $500 or $600 a month, and so we found one Y that would take him. And he was actually a pretty good saver. He was able to identify money that he could set aside. But after spending 2 weeks there, he just didn't feel comfortable, and he was afraid he would go back to using. So that was actually a really good space to have a conversation with our team about what else were his key goals. And so he was back to the street, but we set aside, opened a savings account for him so that he had a way to save up for a little better SRO in a little safer area. And we're working towards saving up over the next 3 months so that he could get that. And he did also, just for purposes of conversation, have the option of staying at a shelter, but again, felt like that wasn't the safest space for him.
I just think from a practical perspective too, right? We figured out that he can get free Advair, but it needs to be mailed. So where do we mail it to, right? His aunt's, he's not going there that often, so we ended up mailing it to the clinic. And again, it's that carrot of you come back to clinic and get your medicine. So it kept him coming in for care.
It allows us to have ongoing conversations and kind of troubleshoot as things come up. And so I think also, you know, letting him drive. So we found an option at the Y, but that wasn't comfortable for him. Validating his concerns and helping us find other options is really a key part of empowerment and engagement as we work on the long-term solution of finding some sustainable housing options for him. By putting all his medicines into a pill box and really demonstrating and practicing the inhaler use, he actually clinically felt a lot better and was able to go from a half pack of tobacco to 2 to 3 cigarettes a day because he was feeling better enough around his breathing to be like, hey, this could be worth quitting, which was exciting for him and for us. And then, you know, getting him to open a savings account is always a real personal position of pride. Having an account where you're actually saving some money into is a real statement that you believe in your future, and something that one of our health advocates is really a strong advocate of, and it's very empowering for patients. And so when she helped him open it online, and then he went there, and lo and behold, they actually gave him a debit card with his name on it, that was very empowering and really encouraged him to keep up the hard work of saving the money for his SRO down payment. So he's someone who medically was not as complicated as psychosocially, which is sometimes what we see for our patients. And in Illinois, he actually will qualify for Medicaid, but as we mentioned before, that process, once he's gotten his 18 documents submitted, is about a 6-month queue to have an active medical card. So during that time, he will continue to follow with us so we can continue to provide his medication support, and allows us to keep coaching him. So after those 4 visits of every week to every 2 weeks, we tend to spread out to maybe every 3 to 4 weeks for that last bit of the 6 months so that patients get the support and the medications they need without seeing us as much and providing more intensive access to some of the other patients. I think we have one other case, but maybe we want to answer some questions since we have about 15 minutes left, or do you want to go over the other case?
If people want to start typing in their questions, if you want to go ahead.
Sure.
I think these are so interesting.
So the second case is for a young woman who was sent to us from the emergency department for right lower quadrant pain. She had been to the emergency department about 5 or 6 times in the 6 months prior to her referral to us, always complaining of right lower quadrant pain. The ER obtained a history of multiple partners with intermittent protection. She had no symptoms of discharge or urinary symptoms. So their concern was for pelvic inflammatory disease. They did an ultrasound, was negative, and they treated her empirically. When she came to our office, this kind of person who's been to the ER 6 times always gives us a pause of, you know, there's more to it than that. And so she met Megan first, and Megan was able to obtain a social history. Go ahead.
Yeah, very guarded, looked down the whole time, just not confident. So slowly getting history, she disclosed that she didn't graduate 8th grade, disclosed that she had a child at 13, and kind of, we capped it at there. She gave me what she was comfortable with, and I walked out of the room and handed it off to Christine. So we never try to push the patients too hard. Our first goal in that assessment is just to make them comfortable, explain the clinic, explain who we are, explain what we're going to do, and get as much information as I can before the patient pulls away or it says you're asking too many questions. So it's a good balance there. Over our time with her, we realized that she had a partner that was 40 at the time when she was 13. They had 5 kids together over 7 years. She didn't have any of those kids right now. They were all placed with relatives. And she just really addressed with us that she had bigger goals and she had things that she wanted to do. So connected her with psychiatry and therapy, which really started boosting confidence and getting her to feel more secure in herself. And then from there, we placed her with a CARA program, and she was able to get a job. She actually works at a children's hospital and is doing a great job. From there, she's getting to see her kids more and is working towards getting her own apartment. So we've really been able to look at the whole person with KB and take it really slow from day one and build trust in who we are to get her to disclose all this information, put the right resources in place, and get her to a place where now she has a job and is working towards getting her own apartment.
So this was her very first job. And when we talked about goals, one of our concerns was that she has very low reading and writing literacy. And as we talked a little bit more about that with her and kind of explored that, we learned that actually her priority was to get a job because she really wanted to be able to see her kids more and have a place they could visit, even if they weren't going to live with her full time. And so we kind of switched gears with her from a focus on literacy and getting her GED to employment currently. She had a real interest in becoming a janitor, which is a great field, and offered opportunities. And so as Megan said, we connected her to the CARA Foundation, which is an awesome resource in Chicago that does employment training and on-the-job support for a year once a person is employed. And so she's been in that program now successfully for 6 months. And to see her come in for follow-up visits around her depression and anxiety, we've provided a lot of education around safe sexual activity as well as safe well woman care and empowering that for her so that she feels more confident to manage those spaces and has had less pain. In addition, addressing her depression has really reduced her pain complaints. Her primary complaint when she came in was pain. Yes, it's pelvic pain, but it's low back pain, it's my knees hurt, and a lot of physical pain, which as we slowly kind of unpackaged the depression and her history of some complex trauma of her own, we were able to really stabilize the pain symptoms by addressing some of her psychosocial barriers and determinants. And now she's very empowered to talk about whatever comes up with her health, as well as see other specialists as needed and get things she's really working towards. And addressing her depression, which is kind of more of a dysthymia, but overlaid with some complex trauma, has been a very slow process. She's really engaged with our therapist and comes in twice a month for therapy. And it really required a psychiatrist-level expertise to get her on the right regimen because our initial kind of take at that wasn't enough to help her feel better. And so having psychiatry available for that higher-level depression consultation was really also important for her.
She's just a different person now. Like,
she really
literally holds her head up.
She comes in proud.
Comes in tall. Yeah, it's so different.
And then, you know, just a simple thing, which isn't so simple. One of her chronic back pain, in addition to treating her depression, we connected her to physical therapy. So that was a great opportunity for her to understand that it's not always a tablet that helps you feel better. There are things and ways you engage with your body that can also be more positive. Now that she's done physical therapy and she feels better, but still has aches and pains, she's like, I'm going to try some yoga. So, you know, I wouldn't say that wasn't a conversation I thought we were going to have when we started, but it's really rewarding to be able to have that conversation. Do you guys want to do you have questions, or I'm not sure what you want?
We do have some questions coming in. If you could advance the slide just one more.
This is her support in the community. Sorry, you would like that.
I think maybe the last slide.
There you go. More than that?
Just one more.
Sorry. I don't know how many more we have. We have some extra links in here. Is there something at the end?
There is, but that's okay. I have a link. Excuse me. So thank you so much, Megan and Dr. Schaefer. This is amazing to hear about and what cool work is being done. We do have a question. Before I get to that question, for participants on the phone, I'm going to drop a link to our evaluation form. Your evaluations help us plan for future events, so please fill this out when you have a chance. So our first question is from Amanda. And for those that want to ask questions, please type it into the chat box at the bottom right-hand corner of your screen. So Amanda asks, this is a sophisticated and comprehensive program. Did it start out that way? Did you have all this laid out before opening the clinic, or did you add more comprehensive care in stages?
So stages. When we started, it was myself and a social worker. Megan wasn't with me at the time, which is the two of us. And so my background is really in public health, and I had been on the receiving end of patients who walked out of this very hospital, Northwestern, when I worked at the Cook County Hospital, which is our big public center, and also at other federally qualified health centers. And so I knew about it from the other end, and so it was an opportunity. But it really evolved, and we kind of grew services as we needed them. Most of our service growth has happened through grants. It's hard to get institutions to invest further in support staff that don't generate billing without grant support, so we grew through grants. But we're really meticulous in terms of data and policy to really try and address the data needs of our administrators to get long-term support for those roles. So the health advocates are an example of that. We did not have that role. We felt like it was a good way to have a social work extender who was doing a lot of the heavy lifting without using that level of a master's degree social worker, and try and keep the model as cost effective as possible.
Okay. We have next question from Janelle. What tips do you have to motivate and get patients to agree to engage family/friends/support people into their care?
One of the things we often do is identify two people, and I usually have them think about it for a week, which person they feel most confident, and then we call together for that first contact on the phone in the office. So if the patient's comfortable, to ask them to say, when I next come in, we'll tell your aunt we're going to call her. And if they're not, we try and kind of coach through that in the series of visits and keep bringing it up. And my stress is that someone at home needs to understand what's going on with you so that we can continue this best care that you've started for yourself. So I think in terms of physical health, it's a little bit easier. When it comes to emotional and psychiatric issues, it's trickier. But I think it's as, if not more important. And so we just we keep talking about it. We also try to normalize patients' health conditions. And if there are reservations, we try and talk about experiences, why it didn't go well, so that we can try and troubleshoot. Mm-hmm. And I do find that with the provider leading that conversation, family members, take it seriously. This doctor stopped to call us, or this, social worker stopped to call us from the hospital is actually a weighted initial in, and takes some of the burden off the patient. And then we also really make sure when we're having those conversations that we validate all the hard work the patient is doing, so that the family member knows that the patient themselves is owning their issues and is succeeding and needs help with X, Y, or Z. So those are the things we try and do. Sometimes patients will have a specific thing they don't want us to mention. Of course, we always respect that. But we try and kind of think through what we can ask of a person. And sometimes when patients don't trust a relative, we might ask for something small, like listening in on a visit or two, just to kind of get them engaged, and then go from there. And the other place we can use is when we have patients, we have a lot of patients who come into care with major crises, like a new cancer or a big heart attack. And from that, we really want to establish power of attorney for healthcare. And so that's another opportunity for those conversations to happen, where it's really critical when someone has had a recent major crisis.
Great. Diane is asking, what is the average length of an initial appointment?
2 hours, if not sometimes a little more.
Yeah,
it's a lengthy visit. We try to prep the patients from the beginning that it's going to be a long visit. When I'm meeting with them, I explain the process of you're going to meet with me, and then you're going to meet with our medical providers, and then you'll meet with a health advocate. You might also see a nurse and a pharmacist, and just kind of explaining the different services we have. So it's definitely a lengthy visit.
Any more questions from participants? While we're waiting, one question came through about will we share these slides? And yes, we will send out a follow-up email after this with a link to the recording, which will be at our website. I'm going to go ahead and drop the link to our website here in the chat box. Usually takes about a day or two to get online. You can follow us on Twitter at NU_NCEAS if you want to keep in touch with what other events we've got going on. And we'll be here for, it looks like we've got 5 more minutes, so we'll wait here if there are any other questions. Again, please fill out this evaluation form. Oh, great. So for Dan again, do you ever do home visits or is it all clinic-based?
So we do some. We used to do more home visits, not a lot, but usually in cases where patients are at the end. And we have a colleague at this institution who currently does those visits. Actually, we trained him. But he is partnered with geriatrics, and they have a home visit provider program. And so for those patients who are homebound at that point, we transition them to Dwayne and the home-based care team here, and they do their home visits. The key place where we found it necessary to do home visits, and occasionally will, is when we're transitioning someone into hospice, because those relationships, a lot of times we're the key community that's cared for them through their new terminal illness. And so we don't want people to feel abandoned. And so usually there's a couple of weeks of overlay where we're still touching base with the patients. And often we'll make a visit a week to the home, or the nurse will go out once a week to the home to continue to offer that support to the patients so they don't feel abandoned as they're transitioning to hospice.
There's a question from Joe. What have been some promising practices to overcome transportation barriers?
So transportation is really hard. We are lucky that we have some bus passes. So we're in Chicago, right? Great public transportation system. So that's one big thing. Another thing is, again, why the Medicaid is so important is teaching patients to use their Medicaid transportation benefits, and really teaching them, like, if your appointment's at 3, say it's at 2 so you're there on time, and how to use that. We've also been very, very lucky in that our institution has given us access to Kaizen, which is a transportation platform. It's kind of like Lyft, but with a little more process around it. It's a platform on the computer that calls the patient when the car arrives. So we have some ability to get patients to and from clinic. We'll use a free ride, like a Kaizen ride, maybe at their first and second visit, but we're constantly coaching, okay, how are you going to budget? How are you going to afford bus cars? Who can drive you? What is your plan? And Kaizen is only eligible during business hours because we have to arrange it. So if you have a late 5 p.m. appointment when our clinics close, how are you going to get there without this resource? So there's a lot of coaching involved and a lot of creative thinking that our health advocates do with patients to brainstorm ways they can get to the clinic.
One thing to add just briefly is that the Kaizen, or the free rides, is new. It's only been around for 6 months. It definitely helps us get people in for that first visit in the door. But it's also really reinforced for us the key of that consistent conversation, because we actually find that for the most part, patients, once they've gotten there once or twice with help, can identify family or friends to get them there. And so by having those consistent conversations and really encouraging, and, you know, if it takes us to call the uncle to say, can you give him a ride in a week? What day is the best day of the week for you? We'll make an appointment that day to get them back. It really gives weight to the value of their medical care and the importance of showing up. And that really gets some support for patients from family and friends around those pieces.
To prove the need for Kaizen, we pulled a lot of data around no-shows and how transportation was a reason for no-shows. So that's how we got the institutional support around that.
Question from Janelle. Where do you even start with patients who have some level of dementia or have not identified family, friend, or support?
Well, to be totally honest, we sometimes are the family, friends, and support for a while. I think it takes time to get enough insight into whether there is someone that can be tapped in for those patients who have very limited capacity. We have a lot of patients with mental illness who have not been diagnosed or are not in care. And for those patients, we actually tend to see them twice a week, once a week for medical, once a week for social at the beginning, to kind of build up the rapport and trust and try and engage that information. It often does take time. For patients with severe mental illness, sometimes it takes us, 3 or 4 months of biweekly visits to really get to a place of knowing who the family is. So I think if it's a dementia or a severe mental illness issue, it will take a lot longer, and we expect that. So we feed patients mac and cheese, instant mac, or oatmeal, And so sometimes that's a reason to come in for a visit around a breakfast or lunch for a meal and to talk to us and have lunch or breakfast, and that may be a social worker or nurse visit. So we try and build rapport those ways and then slowly kind of inch our way in.
We also have great support from the geriatric clinic. So if it is an elderly patient with dementia, we try to get them into geriatrics versus our practice just because they have a social worker there that can help, or Dwayne can go into the home and do the home-based program. We're, I would say, also really aggressive if patients that we are worried about competency, if they're admitted into the hospital, we try to get psych and neuropsych testing involved right away to determine competency, because it's a lot easier to get some of that stuff done while the patient's in-house. So then looking to guardianship there, if it needs to be a state guardian, right, that all happens better when they're in the hospital because it's an emergent need. It's something we kind of slowly chip away at the clinic, but as soon as something occurs where they're admitted, or if we know about them before they're in clinic and they're still in the hospital, advocating for those pieces.
So last question from Lizette, what kind of training has been helpful to give employees the tools to build trust with patients?
You know, we're kind of lucky in that our very first front desk person has really good people skills. So when we started, it was myself as a medical provider, one social worker, and a front-end person who did registration. And Debbie is a phenomenal people person. She's just kind and open and warm, and so she kind of sets the very first tone when patients walk in the door. And so patients, I often joked in the first year that patients came back to see Debbie, not me, but that wasn't really a joke. It's actually true. And having a team of people who are very open to patients of all sizes, odors, habituses, clothing, attire, numbers of bags acquired was actually really important for us and part of our culture. And so, you know, she really not only welcomed and registered people, she kind of managed the waiting room. So she would kind of keep tabs on if someone else was uncomfortable with someone's behavior, she would address it, or she might bring someone to the back who had 10 bags so that they could make room for other people. So I think, you know, we did kind of screen for comfort with homelessness and severe mental illness, and then have also provided ongoing education to our team about how to handle, how to de-escalate, when it's appropriate to engage other team members, how do you keep safe, but also really have been very fortunate to kind of luck into some initial team members who are just really good people. And so that helps us get started off the right foot. But I do think that, you know, every member of the team has to want to engage with the population for it to truly be successful, because, you know, patients often come back to see Debbie for her Debbie special, which is otherwise known as mac and cheese with a side of canned peaches, because she's a great person and I would come to see Debbie. And so that's just as much of a win as if they're coming back to see Megan or myself.
When we're onboarding new staff, we have them spend a lot of time observing. A big area of what we do is we like to have them observe a whole new patient appointment so that they start from coming in the room with me to being in the room with the provider to being in the room with the pharmacist, the health advocate, all pieces of that first visit, because that shows kind of how everybody interacts with the patient and gives them a feel for what the patient's going through. So that's a big part of it as well.
That's great. Well, we're a little bit over time, so we will stop taking any questions at this point. Thank you so much to our speakers. This was just excellent and so great to hear about. Thank you to our participants for your questions and for joining us. I'm going to drop the link to the evaluation here one more time. And if you have any questions after this, I'm including our email address that you can reach us here in the chat box. It's contact@scoh.education.org. And so with that, thank you all so much and have a great rest of your day.